Well, heart failure hospitalization, we have a tendency to feel that if the guy gets admitted with severe orthopnea, PND, pedal edema, congestion, etc., you treat him 2, 3, 4 days, he is out of ICU, he is stable, his symptoms have gone, his congestion is gone, and we are back to square one. Is it so? Well, it's definitely not so, because as you can see, every heart failure hospitalization carries an ominous prognosis. On the right side, you can see every up spike is the increase in morbidity and mortality with every episode of hospitalization or every ADHF, acute decompensated heart failure episode, ultimately culminating into death. And on the middle part, if you can see, after first hospitalization, the median survival is 2.5 years, which drops to say around less than a year by the fourth hospitalization. So every hospitalization carries an extremely ominous prognosis. That is something which needs to be looked into. And there is an extensive data, literature, therapeutic options which have come up in last 5 years. A lot of guidelines have come, and we expect that that would affect the patient's overall outcome. What is the reality? If you see from 2000 to something around 2017, there is no significant impact in 1 year survival, 5 year survival, or 10-year survival. 10-year survival has gone up from 20 to at max 25%. So why we fail to gain the benefits of the data, benefits of the guidelines? Well, heart failure hospitalization is an extremely vulnerable phase, and it's an opportunity for course correction. Within 30 days of hospitalization, almost 25% of the patients will get readmitted, and second admission worsens the prognosis still further. 10% of the people will die within 30 days. And Trivandrum Heart Failure Registry, if you see, the readmission rate is something around 50%, 30-day mortality is something like 30%. So in India, the situation is worse. And what is still worse, that it happens in a younger population. Our population is on an average 10 years younger than the Western counterparts. So it becomes all the more imperative that we be more aggressive in this. Now, what do the foundational 4 guidelines say? Because the trials came first ACE inhibitor, so we say that, okay, optimize ACE inhibitor, then you start beta blocker. Once beta blockers are optimized, then you start MRAs, then change over to ARNI, those who are on ACE-ARB and not controlled, and lastly SGLT2. This chronology is not scientifically based. And if you go by this chronology, which was the conventional thinking, it takes something like half a year to 1 year to reach the foundational 4 therapy, and that is when your maximum benefit would start. But what is the real fact? If you see the trials of beta blockers, MRAs, ARNI, SGLT2, the benefit starts within days, and within 2 weeks to 4 weeks, the benefit of mortality reduction becomes statistically significant. This is consistently seen across all the trials. So what is the corollary of this is that delayed initiation of any of these 4 drugs in an eligible patient leads them to a needless exposure to a clinical risk, which is mortality as well as morbidity. Whatever sketchy data we have, whether we can start these therapies in patients who are acutely decompensated, we have few sketchy data like Soloist worsening heart failure trial, Impulse, Pioneer HF. Even in CBIS beta blocker trial, we did have class 4 patients. So we can extrapolate from this. It's not going to be possible to collect all this data, but we can extrapolate that early initiation can potentially make a difference. Why majority of times we don't initiate altogether? Because we are worried about side effects, the commonest side effects being hypotension, hyperkalemia, as well as worsening of renal function. These are few of the parameters, but believe me friends, when you combine together, the incidence of side effects comes down. When you give SGLT2 inhibitors, there is a decreased incidence of hyperkalemia, there is a slower progression of renal dysfunction, and it does not have any significant effect on patients' hemodynamics. So it becomes very easy to start in an hospitalized patients. When you replace ACE inhibitor or ARB with ARNI, again your hyperkalemia comes down. So your roadblocks to starting multitherapy becomes easier if you start all four as fast as possible. There is another problem of clinical inertia, clinician's inertia and patient non-compliance. It has been shown that if you start foundational 4 therapy during hospitalization, the clinical benefit, the symptomatic benefit which is seen, people tend to associate it with it's a successful molecule. While if the guy is decongested with diuretics and 1 or 2 foundational therapy, he feels better, goes home, and then you give him an expensive therapy or additional tablets, he is going to refuse, no, I am already feeling better. Not knowing that, just feeling better is not enough, you need to live longer. And here it is seen that if the green bars are the patients where therapy was started before discharge and red bars it was after discharge. At the end of 60 to 90 days, 90% were on beta blocker if it was started in hospital, 30% when it was started late. And similar data are there for ARNI and MRA. So starting the therapy early in the course takes care of clinical inertia and improves the GDMT penetration in those group of patients. So that's a very important data, and that's why guidelines say that this is perception, expert opinion, extrapolation based recommendation that significant clinically relevant benefit occur within 30 days of initiation of each class of drug. And all these benefits are not overlapping, they are independent of each other. So overall 75% reduction with 4 therapies, but if you start all together, it is better. The European Heart Association guidelines, if you see the middle rows B, that is for hospitalized patients, they say that in hospital you start with beta blockers, SGLT2 inhibitors, and depending upon the patient's hemodynamic phenotypes, you start them on initial dose of ARNI and beta blocker. SGLT2 and MRA does not need much of the titration. Towards the end of the hospitalization, call them at a follow-up every week so that you can assess the patient and up-titrate the therapy so that by the end of 4 weeks, the patient, if he tolerates, he is on the maximal recommended dose of all foundational 4 therapy, that is an accelerated schedule. And though we do not have data, there is a modeling, there is a calculation. The engineers and statisticians and people have combined the data. If you see the sequence 1, where every 6 weeks, first you start RASI, then at the end of another 6 weeks, beta blocker up titration, then MRA, then ARNI, then SGLT2, it reduces the probability of adverse event in 1,000 patients from 280 to 128. We are happy about it. We were happy about it. But see the sequence 2, wherein within 4 weeks, within 1 week, you start them on RASI or ARNI, you start MRS, SGLT2, everything, full titration within 4 weeks, you have additional 47% reduction in, can I borrow from my previous speaker a couple of minutes? All right. And it is said that in patients experiencing mild decrease in kidney function or asymptomatic reduction in blood pressure during heart failure hospitalization should not be an indication to reduce or stop any therapy. If the blood pressure drops down to 85, he is asymptomatic, just don't bother. In addition to foundational 4 therapy, you have to look into the other aspects, iron deficiency, etc. And if the patient had an acute decompensation on top of classical therapy, go for vericiguat, etc. Device therapy, etc. I don't think should be considered at the time of hospitalization in majority of patients. You should be looking for comorbidities, particularly sleep disordered breathing. Rest of the things have already been discussed. And hospitalization episode must be seen as an opportunity to optimize all medical therapy. GDMT classically are grossly underused. Only 25% of eligible patients receive triple therapy, and only 1% receive the full optimal dose of triple therapy as per this registry. And over the decade, 2019 to 17, unfortunately, we have not improved. So friends, this is my last slide. There is, because of the rapid escalation of therapy, there is a rapid improvement in heart status, ejection fraction, reduction in hospitalization, reduction in rehospitalization, mortality, improved use, adherence, persistence, and it can overcome inertia. Hospitalization, you have enough time for patient evaluation, you have a team support, we have a family member who is available, and thus it becomes a great therapy. This is my last slide. You can read through. Thank you very much.